Hey, what's up, Fairlawn Ambulance Corps? It's John Barr back again for another episode. This time we're going to talk about pediatric respiratory emergencies. So let's get into it. Before we start, let's read the disclaimer as usual. Take a look at that. All right, so this is a very anxiety-provoking call. We don't see a lot of kids in EMS. Many EMS providers are not comfortable with this. It's only 13% of EMS calls, but of those, 9% are respiratory distress, and of those, 3.9% are asthma related. So I think talking about pediatric respiratory distress is well worth it as a review here. So what are we going to discuss today? We'll talk about how to assess a pediatric patient, what are the differences in pediatric airway anatomy. We'll talk about the pre-hospital management of respiratory distress in kids, as well as some common respiratory conditions and how they might be treated in a pre-hospital setting. So, how are we going to assess kids? So in kids, the key thing to know is the pediatric assessment triangle. That stands for appearance, work of breathing, and circulation to the skin. So if we start with appearance, sometimes people use this acronym TICLS to remember it, but it stands for tone. So is the baby floppy or do they have good muscle tone? How is the baby interacting? Are they interacting normally? Are they consolable by the parents? How is their gaze, or what are they looking at? And then what is their speech and cry doing? Then we're going to look at work of breathing. So are they making abnormal sounds like grunting or stridor? Are they tripoding in an abnormal position? Do you see retractions, which are signs of accessory muscle use or increased work of breathing? Is there flaring of the nose? Or are they not even breathing at all and are apneic? All these are signs of a kid who's in trouble, who's in respiratory distress. And then we'll look at the circulation to the skin, and I'll show you a picture of each of these, but pallor, mottling, and cyanosis. So let's start with the work of breathing. So this is really key to identify a kid in respiratory distress. So look at their nose. Are they ala or those nose passages flaring out? Then we're going to look at accessory muscle use and retractions. So these can be suprasternal, they can be intercostal here at the ribs, or you can see belly breathing and use of abdominal accessory muscles, all of which are not good. The tripod position is also a sign that the kid is in respiratory distress and you should recognize it. Note that don't be falsely reassured. You say, oh, they're not cyanotic, they're okay. No, cyanosis is a late sign of respiratory distress. You want to see these signs of work of breathing increasing well before they get cyanotic and intervene on that. So instead I'd show you a picture. This is what pallor looks like. Look how the skin is much paler here compared to here. This is perioral cyanosis or bluing of the tissue, and that can be a sign that there's not enough oxygen. And then this leg here shows mottling. Now it might be a little hard to see in the photo, but I'm going to try to trace some of the mottled areas, like these little lines here. You can see another little outline there, and that's a sign of circulatory issues. Vital signs are vital, but remembering kids, they're different than adults. They're going to have different vital signs. So notice how, as you get older, how the vital signs shift. So respiratory rate is generally going to fall as you get older. So is heart rate. But blood pressure rises as you get older, right? So this is getting bigger and bigger and bigger, almost towards your adult blood pressure down here. Now, it's very important to get good vital signs in kids. It can often be challenging. So let's remember some differences with adults. One, in infants, we're going to go for a brachial pulse. Also note that an infant greater than 220 or a kid greater than 180 in heart rate is usually always abnormal. And unlike in adults where we look for pulselessness to decide when to start CPR, in kids, if the heart rate's less than 60 and there are signs of poor perfusion, you should start CPR. Additionally, you need to be opportunistic when getting kids' vitals, because once you make them upset with stethoscopes and blood pressure cuffs, you may never have another chance to get a good respiratory rate. So try to get it while they're calm. One other kind of scary thing that if you haven't taken care of a lot of young kids, you may not be aware of is something called periodic breathing, which are these weird pauses followed by rapid breaths. Just keep an eye out for that. Know that that can happen. If you've never seen it before, it just might freak you out a little bit. So I pointed out here that this can happen in young infants. As for blood pressure, make sure to use the right size cuff. Here's a little formula to calculate what the BP should be, but I don't recommend doing any math on scene, and I'll show you some tools for that. Also, use the parents. If the kid stays calm and they're calm in the parents' arms, that's when you should get your assessment. That's when to get your vitals, because you're going to get better assessments that way. So I mentioned we don't want to do math on scene. Well, what can give us equipment sizes and dosing and a lot of information? A weight-based tape, such as a Broslow tape, and I don't endorse any particular brand or product here, but Broslow is one of the most common. There's also the hand Devi system, which uses age to give you an estimated dosing weight and associated in equipment and drug dosing, so that's really helpful. They also have an app for this, which is really helpful. So let's summarize the pediatric assessment section. So pediatric assessment triangle can help you rapidly determine how sick a child is based on their appearance, work of breathing, and circulation. Remember, vitals are vital, and kids have different vitals than adults, and be opportunistic when getting them. Get them when the kid's calm if you can. And lastly, we don't do math on scene. Use a length-based tape, use an app, or an age-based system that helps you get the appropriate doses, equipment sizes, vitals, etc. All right, let's talk about some anatomic differences. 1. Kids have big heads. And because of this, when you lay them flat, you may need to make adjustments to keep their airway open, such as a blanket roll. They also have big tongues, big tonsils, and floppy epiglottis, and that's the piece of tissue that covers the windpipe when you're eating and covers the food pipe when you're breathing. And for ALS providers who are going to be doing intubation, just remember the narrowest part of the airway in kids is actually the subglottic and cricoid cartilage area, as opposed to adults when it's the vocal cords. All right, let's talk about respiratory distress in the pre-hospital setting. Now, kids don't come with a diagnosis. In the beginning, you're not going to know why they're in respiratory distress, but everyone is going to need some form of supportive care, and you can do this at the BLS level. Use the least invasive method possible. So start with your normal breather and even use blow-by. If it looks like the kid's getting worse and they're getting anxious, try blow-by, see if it helps. You're then going to escalate to forms of positive pressure ventilation if you need to, such as CPAP, BVM, supraglottics, and as a very last resort, endotracheal intubation. More on that later. So what about the kid who's wheezing? You may not know why they're wheezing, but you know that they're wheezing and they're probably going to benefit from bronchodilators. And while not all that wheezes is asthma, often it is. And so albuterol, steroids, mag, giving fluids with your magnesium is really important to prevent low blood pressure. Now, epi. You can use intramuscular epi for severe asthma. Typically, this is going to be an ALS thing after you've tried the above stuff first, and then terbutaline after that in severe refractory asthmatics. Now, I mentioned not all that wheezes is asthma. Well, anaphylaxis also wheezes, and that epi is going to be key. But so does airway foreign body, and the information you get on scene as a BLS provider may be really helpful for identifying that. Infectious processes such as pneumonia and bronchiolitis can also cause wheezing, and in bronchiolitis specifically, suctioning, which you can do at the BLS level and get those secretions out, is really important. Now, what about stridor, that squeaky airway sound, high pitch? Well, if it's due to croup or an infectious process, it's going to be racemic epi and steroids, and it generally doesn't hurt to try racemic epi, but you're going to need ALS call for this. So I said no math on scene. This is more for ALS providers, but I'll include a little reference to Peds Med dosing. Again, use your favorite app or system to get the right doses. Now, I mentioned endotracheal intubation as a last resort. What do we know about pediatric intubation? Well, we know that we as EMS providers do not intubate kids a lot. In fact, in this one study, it was only 0.7% of all calls for age less than 15. And note this, especially in rural environments, only 50% of the state's medics attempted one intubation. And the truth of the matter is any procedure in medicine that we don't do often, we're not going to be good at. And the evidence shows that to be the case for this as well. We are not good at intubating kids. In fact, in this study, 18% of cases were unable to be intubated with by paramedics. That's pretty high. It's almost one in five almost. Furthermore, there's a number of studies building evidence that says, well, even if we do intubate the kid, we're not saving their life. And that's concerning, because if we're not saving lives with this intervention, maybe we shouldn't be doing it. So in one clinical trial, they showed there was no difference between just using bag valve mask and endotracheal intubation. So I think what that tells you is that BLS skills are really important. In fact, sometimes, good BLS before good ALS, and I'll say that and I'll say it again. It's really important to have good BLS skills. Now, in some of these other data sets, they found actually worsened mortality with kids who are intubated. Now, it's hard to know what to make of this because kids who get intubated are probably sicker than those that aren't, but they did attempt to control for that. And when they control for the injury severity scores, kids with intubation did worse. So I think what it's telling us is that good bag valve mask ventilation is really important in pre-hospital settings, and intubation should really be reserved as the method of last resort. Now, what about supraglottic airways? These are getting more and more popular. They're trickling down into BLS world in some areas. So you should know a little bit about them. They're a pretty reasonable option. You can use in kids. They come in kid sizes. There's the LMA type ones. These are like the iGel style ones here. Again, no particular endorsements. This is the King airway here. Now, I particularly like the iGels because I've used them and they have no cuff. See, these have cuffs, and in the pre-hospital setting, we're great at breaking things. And if there's no cuff to pop, or nothing to break, it's going to be advantageous, and that seems to be, and the iGel has no real breakable parts, it's all one piece. In case you need like a little reference, I've just included here for LMA style and King style. Again, we're not doing math on scene, so have your favorite app or reference available for sizing these. So let's summarize pre-hospital management and respiratory stress. Everyone's going to get supportive care. BVM is key for everyone. Intubation is the last resort. Now, if the kid's wheezing, and it's probably asthma, nebs, steroids, mag, and fluids are going to be the mainstay. For stridor, racemic epi and steroids are going to be the mainstay. And IM epi may be the next step after this if this fails. So with that, let's review some common conditions. And I've been alluding to this, but for asthma, we've talked about the treatment, but what about the pathophysiology here? So in the asthmatic airway, it's going to be thickened and inflamed. There also is constriction or tight, smooth muscles, okay? And that's going to lead to the respiratory distress. Now, albumin ipratropium help dilate and open that smooth muscle. The steroids help take away the inflammation, and taken together, they can help with this. Now, epi and mag are also bronchodilatory and work on the smooth muscles. Terbutaline as well. So that's going to be key in the management of these patients. You're going to need ALS, but you can still provide good support in the interim until you can get ALS on scene. Now, I do include as a reference to the CHOP clinical pathways. They're a really helpful free reference available online, but you can check out, which give a lot of good emergency information if you need help taking care of kids. Now, what about anaphylaxis? So in anaphylaxis compared to asthma, so anaphylaxis is a life-threatening allergic reaction. Typically very rapid onset, and the key thing with this is that there's two or more systems involved, so there's often, it can be a GI component, particularly if it was an ingested allergen like peanut butter, but also skin, and the rash can tip you off that this is anaphylaxis. And oftentimes the history is there is some allergen present, like, oh, hey, I accidentally ate peanuts, now I'm having this. So really important at the BLS level, epinephrine, and that's going to be intramuscular epinephrine. Comes in many brands such as the EpiPen or AviQ, and some of these, like the newer AviQs, will actually talk to you like an AED will. So treatment for this, besides the epinephrine, is going to be steroids and double histamine blockade with diphenhydramine and famotidine, and these are going to be ALS skills here, but so you're going to need to call ALS. Now, sometimes people will take their EpiPen and say, oh, I took my EpiPen, I'm better now. Don't be falsely reassured. These reactions can be biphasic. They can come back. These are the risk factors that make it more likely that it will come back. And note that severe asthma is a risk factor because asthma and allergies often go together. So often kids who have anaphylaxis are also bad asthmatics. So key thing to keep in mind there. These patients should generally go to the hospital if they receive IM-EPI, and typically we'll observe them for at least 4 to 6 hours. All right, what about bronchiolitis? So bronchiolitis is gonna basically usually be triggered by some type of viral URI. They usually start with a fever and a cough and runny nose, and then eventually you'll get lower airway systems like wheezing and rales. Now, I point this condition out because it's really common during flu virus season and winter seasons, and you can do the key intervention here, which is suctioning, is the mainstay of treatment of this. And so you can suction a lot of those secretions out, which can make a real big difference for these kids. Now, what about croup? So we talked about stridor before. We talked about racemic epi and steroids. This is the case where those two interventions are really going to help you the most. And this is that seal bark cough. Mostly viral etiologies. And again, you can see that respiratory distress, and this gets better typically with racemic epinephrine, that's the nebulized one, and steroids. Okay, so let's summarize here. So for asthma, neb, steroids, and MAG are going to be mainstay of treatment. ALS, anaphylaxis, you're going to use episteroids and histamine blockade. Again, ALS. And bronchiolitis, the mainstay is going to be a BLS intervention of suctioning here. You can consider albuterol, but it's not routinely recommended in all comers. And then croup, racemic epi, and steroids, again ALS here, but you can still support these kids and evaluate for other causes such as airway foreign body that are leading to the stridor. Some references for you. Thank you guys for listening in. Stay safe out there and see you on the next one.